Hi, good afternoon, everyone, again, and welcome to the Doctor on Call on the Parking Lot. I'm Dr. MaximoGomezNacer. This is a broadcast from Union City, New Jersey, and this is a series of interventions, basically, or conversations to present how to do the boards in the United States or to conduct some refreshment of activities that can be useful for the general practitioner that wanted to come to the United States. Now, in the prior cases, we were seeing neurology, and today we would like to see some of the evaluations conducted in the specialty of psychiatry. So we do observations like in all observations in medicine, but the observations try to be more focused to a specific aspect, such as the attitude, the affect, the appearance of the patient, the attention of the patient, the concentration of the patient, as well as the sensory, the speech, the motor response, the mood of the patient, the thought, the contents of the thoughts, the form of the thoughts, the intellect, the intelligence, as well as the insight, judgment, and specifically evaluating the possibility of aggression to self or to others in the form of either suicidality or homicidality. People can be suicidal or homicidal in some cases. So this is how we conduct this exam. So let's go one by one to see how this goes. The appearance, basically, we look at the patient, specifically the area around the eyes, and we look at the facial expression. We see if the patient has a sad facial expression or a happy facial expression, and we documented it. But the muscles can be easily pretended change in the muscles. So we mostly concentrate in the area around the eyes, which is more specific, less. It's harder to pretend that the person is sad when you're looking in this particular area. Also, in the appearance, we look for the clothes. How is the person? If it is clean, if the hygiene is proper, the combination of the clothes. Some patients may come with Santa Claus combination, with carnival combination, with ready to go to a wedding, and then you documented it. This is a very unusual combination of clothes, objectively. You don't put your interpretation, just the patient come with Santa Claus hat, with a carnival shirt, and with trousers are ready for a wedding, for example, black color. The shoes are sneakers, for example. So this is the kind of the appearance. So we can put it as observation. Also, if the person is disheveled, the person has proper shave, and in general, this is all part of the appearance. The affect is what the psychiatrist does. So the patient can say, for example, that he's sad, but he's smiling, or the eyes doesn't tell you the patient is sad. It's actually very energetic. You don't see that the patient is sad. Or on the contrary, the patient say, no, I am fine, but you see the facial expression again, and this is the affect. You say, is his mood congruent or non-congruent? The attitude, we look for cooperation. For example, many patients don't want to cooperate, and you can see that in the way the person sits. If it sits forward, leaning forward, let's say with one foot in the front of the other one, like ready, attentive, paying attention to what you're doing. The patient is more laid back, is with the arms crossed, with the legs crossed, and the attention, and then the concentration. We also look for signs of the person is concentrated, or if it is distracted and just looking to the sides and does not understand what you're saying, and you have to be repeating the information. Now, for the mood, we actually ask the patient how the patient is feeling. The patient is telling you if it is sad or if it is what is the main reason of the consult. So in the mood, this is also one part that we document. The movement, we try to address psychomotor movement. Like some person, I constantly just looking for, like, seeming to be responding to auditory or visual hallucination, or cannot stand still in the chair and is constantly moving back and forth, or when the patient is standing, is constantly pacing back and forth, like ready to jump into a person. This kind of observations where we put it. By the way, the psychiatrists are among the healthcare professionals, one of the most have the assaults. But we use our judgment ourselves to try to make sure that we keep a good communication with the patient, a good visual eye-to-eye communication and a proper verbal communication to prevent assaults. So we also saw there the movement, we saw the sensory. The sensory, basically, we see the patient, if the patient is alert, awake, oriented. And this is something we're going to also review when we see at the mini mental exam, which we're going to be following. The mini mental exam is more objective, is specific, this question structure that we ask. The speech is important as well. In the speech, we're going to see if the speech is very fast, like having money, I was very high, this kind of hyper, or the patient is very slow, like a very broken language at different speed, at different velocity, like that indicate possible the presence of depression. Now we also look at the thoughts, the content of the thoughts. If the patient has abstract thinking, concrete thinking, and the form of the thought, if he has pressure, especially speaking very fast, or also has derailment, or he has disorganized speech. And in the thoughts particularly, we look at one particular type of thought that we're going to discuss later on, which is, well, the homicidal or suicidal thoughts. Now, we also look for the intelligence in general by asking the patient the education, by asking the patient several questions that we can go into the mini mental exams. And also we can see the perceptions of the patient. Now, the perceptions are actually the hallucinations. Perception can be visual, tactile, auditory. So, for example, the patients can have visual hallucinations, generally are associated with substance intoxication, like cocaine or alcohol, while the auditory hallucinations tend to be more present in patients with schizophrenia. The tactile hallucinations can be present with some other forms of schizophrenia. Now, also, just for the sake of the concept, what is a delusion? Delusion is a false belief. So when we're addressing the thoughts, we can go for delusions. Some people can come saying, for example, that they are he or she is the queen of, or the king of Mars, or the king of Jupiter, and he came in a spacecraft, things like that. And those are completely weird thoughts. Some people can have other thoughts and say, well, yes, I am a medical doctor, of course. And then, yes, you are, okay, I am a doctor, but then you verify. Where did you graduate in? 1990. What is school? Instituto Superior de Ciencias Médicas de La Habana. What is the USMLE ECFNG, Educational Commission for Foreign Medical Graduates number? 05289111-1. Where do you go to postgraduate training? Lincoln Medical Mental Health Center. What year? 2002, 2003. What is the telephone? It's 918-578-4883, for example. So you just verify. Psychiatry is a specialty of verifying information, what you cannot get from the patient, because most patients, when it comes to you, can be disorganized and you can immediately grasp. But if not, you always verify with family members, with the wife, with the friends, with the people that bring the patient, and with set points of references. So this is in general. Now, we also check the judgment, for example. The judgment can be simply assessed by saying, well, you find a letter in the street, and the letter has a name, an address, and the stamp is in it, and it's sealed, and you suspect there's money on it, and what would you do? And some people, antisocial, sociopaths, can say, well, keeping the money. The answer that we are looking for in psychiatry is, well, the person saying, well, or doing actually delivering the letter, because this is not for you. This is not the letter. This is not the money that is coming for you. It's the money which is coming with a name for a specific person. Unless you are a sociopath or antisocial person, you don't touch that money. So basically, this is something that we address. This is called the judgment part. In the judgment part, by the way, we're going to see that later on, and when we address the personalities and when we address the different types of social structure that we can see with the pathologies that we can see. Now, in the inside, how do we test the inside? We simply ask the patient, why you're here, and the patient tells you, well, I'm here because I'm depressed, or because of this, or because of that, and I need some help. I'm looking for help. So those are the kind of insight that you're looking for. The patient sometimes loses completely track of their own sense, and that is the condition of the insight that we are looking. Now, finally, we look again for the most important elements, which is when it comes to deprive a person from the civil rights, because the psychiatrists do have that power, and this is not a power to ever be abused. It's a power to be used very carefully with a high level of social trust and ethics, and so it comes with how do you address those people that are in, let's say, in severe psychomotor agitation, or can have some form of aggression, display aggression as evidenced by verbal and physical confrontation, or how do you address, for example, people that are actually in suicidal thoughts, so we have a plan, or has homicidal thought. And this is something we're going to be discussing in the following sessions as part of the vignettes that usually come for the boards. So we're going to see these cases, and we'll see what is the next scenario, what we should do, and what they expected us to do. Well, this is all for now. I hope you find it at least interesting. This is part of the skills for a more technical English language, and I hope you like it and come back again soon. Thank you very much, and have a wonderful night. Thanks.